Hi everyone, a warm welcome to the final session of our marathon series. I hope everyone has learned something new from whatever you know. I hope it's refined your skills till now, whatever we discussed. Today will be the final session of this marathon series, so we'll be going in detail about the procedure skills. Obviously, I'll not be able to demonstrate most of the procedure skills like suturing or knot tying or abscess drainage, but we'll be discussing in detail what are the things that we are supposed to do before we start the procedure station and after we finish the procedure station. What are the things that we need to follow? So that is what we'll be trying to discuss here. Yeah, I'll start off with the first thing in the procedure station, that is before we start the procedure station, what are the things that we need to go through? So this is what we'll be discussing today. Mostly the procedure station, what are the stations that we see in a procedure in the final exam, and how do you maintain asepsis, how do you prepare for any procedure station that's given, regarding some questions regarding local anesthesia, suturing of the wounds, debridement, and WHO safety surgical checklist. And we'll try to have a small mock circuit where I'll be talking about different stations, mix of all the stations that we discussed in the past few days. So that will be, this is the whole protocol that we'll be following for the next 1.5 to 2 hours. So going on to the procedure station. So what are the things that we have to remember is very important. We all know, most of you might be already knowing how to suture, how to catheterize. That doesn't matter here. So the thing is, how are you going to convince the patient that you're going to catheterize them? How are you talking to the patient? Have you explained everything to the patient in detail? Has the patient given a proper consent? Have you maintained dignity of the patient? Are your moral and ethical values good? Your professionalism is good. So this is what is going to matter in your final exam, and not the procedure per se. Okay, the procedure might go here and there, but if you're missing all the steps, you're going to lose a lot of marks. So that is what we'll be discussing here today. So I'll be briefly going through this stepwise. A confident and rehearsed technique. So I want to again tell you, this is exam is more of an acting rather than you being a doctor yourself. Okay, you might be a super specialist, you might be a gastroenterologist, doesn't matter here. You have to be a very good actor when it comes to the exam. You should be confident enough. See, for example, you might not be prepared for obstetrician. For example, you don't know how to do abscess drainage. You have done abscess drainage, but you don't know how to do a protocol wise abscess drainage. But you have to be really confident that it should not show up in your face. You should not get scared. Okay, so that for that I'll give a proper framework that you're supposed to follow. Please follow this framework for all the procedure stations. That will make it very easy for you overall. So rehearse technique. Part B is more about rehearsals. The more you rehearse, the better will be your performance. So that's why I told you acting. So acting is not going to come to you in one day. It is going to take some time. So that's why preparation here needs around 3 months of complete rehearsal, complete practice, repeated practice, practicing with colleagues, practicing with friends, practicing as a friend of a mirror. That is what is going to help you clear the exam and procedure or any station in that matter. Asepsis is doubtful. See, the problem here is it's going to take a lot of time for you to, but washing his hands is completely most important, most necessary, or else you're going to lose marks. Apart from this, setting up the equipment, maintaining the they might not tell you to do that. For example, scrubbing, painting, draping, because this part will be skipped because it's 6 minute station. You might be able to skip this, but you should tell that I'll be maintaining proper asepsis orally. Okay, then the exam will tell you, consider the asepsis maintained, you can proceed with suturing or catheterizing or whatever it is. Patient safety. So this is where we always falter. We are always so concentrated on that procedure, on that examination, on this taking. We always forget about patient safety. We are not even bothered about what exactly the patient is going through. Right? For example, you put a catheter inside, the urine is not draining. You are just concerned about inflating the bulb. You're going to lose marks. Okay, don't know if it's in the urethra, it's going to cause discomfort to the patient. If you're doing it repeatedly, so for example, suturing, if you're not waiting for the local anesthesia to act and you're just giving it like that, you're not done a test dose, it's all putting, these are all things are putting the patient in risk. So considering patient safety is very important rather than completing your procedure. That's very important. This is very important. Consent is not something that you just go and explain. Yeah, so this is what I'll be doing today. No, that is not how it works. It has to be proper. You have to make the patient understand properly in a layman language. Do not use medical terms. You just go inside. I'll be catheterizing you today. I'll be putting a tube down there, so that's going to cause some pain. Is it okay? No, it has to be very carefully, thoroughly practiced and explained to the patient. Then only consent. So I'll be going through in detail when each of the station comes. And what we do is most of the times disposal of the sharps. We are concerned more about the procedure here, so forget to dispose the sharps or sharpens. Why is it important? Here, not only the patient safety, safety of the surgeon, also the safety of the student also is important. So they're looking at, are you yourself safe? Are you at a high risk of getting infected yourself and transmitting that? So here, safe disposal of sharps and etc. after the procedure is also important. And for example, as a nevus excision station, there you have to excise the nevus and send it for handling. So how are you handling the specimen? Are you doing a proper checklist? Are you properly filling up the form, pathological form? Okay, so that is also they are looking at. And a sensible answer to Viva. I think this is the least important of everything that we discussed. It's very simple and straightforward Viva question. So, what is the differential diagnosis? So, how do you manage something like that? It's very simple Viva. Here, when it comes to part B, it's more about the way you are acting rather than your Viva. So, Viva carries the minimal marks. So, it's more about the other things that we discussed previously. Okay, so what is the things that, so these are the things that actually makes you get marks. So what are the things that actually you lose marks? Where do you lose marks? So breaking sterility is one of the things. For example, you're not prepared the surface well, you're not draped the surface or not painted the surface, you're not wearing a glove. Some people actually forget to wear the gloves or wash their hands, so you lose marks. Needle stick, again, improper disposal of the sharps or improper disposal of other materials that have been used. Silent performance everywhere is a big negative on your performance. If you're silent, you have to keep on talking to the patient. Most of the times what the students do is they just finish the procedure and they wait till the end of the procedure to explain post-op complications, follow-up, routine, daily routine, etc. No, don't do that. You have to do it simultaneously. So you have to be very conscious while doing the suturing. You have to explain to the patient what you're doing. Every step has to be explained to the patient. Then only you can proceed further. And during the procedure itself, make sure that you explain the post-op complications, what he has to look for, when he has to follow up, what are the things that he has to take care of, everything. Rush performance, because it's 6 minute station, we always trying to rush. For example, you might forget washing your hands, you might forget giving a local anesthesia, you might forget disposing of shower. Don't do that. That is where the practice comes in. 6 minutes is more than enough for all the procedure. There is no way that you cannot complete a procedure in 6 minutes. That is how the MRCS procedure stations are going through. Okay, so that is very important. So remember, if you are not able to complete any procedure in 6 minutes, then you are doing something wrong. It is not. It is, if anyone says the procedure is long, they are completely wrong. Okay, procedure is very simple. It can be completed in 6 minutes. If you're not able to do it, then you're doing it wrong. That is one thing that you remember. Using a wrong material, for example, the suture, the catheter size, everything has to be very important. You're using the number of gauzes for cleaning of the genital area. Everything is important. If you're using a normal saline to inflate the catheter bulb, then you're going to lose marks, right? So this is very important. We are just concerned about the procedure, so we forget to explain the aftercare, whether the patient can take bath, when he has to visit a GP, when he has to come to the emergency. So all these things actually matter. So that's what I'll be discussing in detail further stations, upcoming stations. I hope the basics have been understood here. So remembering all this, we'll go further into the stations. So framework. So now we'll be discussing in detail about all the, so this has to be applied to all the stations. What are the things that you have to follow before you actually begin any particular station? Except one exception here would be the OT listing, because there is nothing there. OT listing is more of a theoretical part and it's very easy to clear. So yeah, so what first is, once you enter the station, the first thing is introduction. Hi, I'm Dr. Rakshit. I am one of the exam candidates today. Okay, you introduced yourself. Then what is the confirm the identity of the patient? Hi, I am Dr. One of the exam candidates today. May I confirm your name and age, please? Okay, name and age. So this is very important. Don't ask for date of birth or age. Name and age should be very simple and it's very straightforward and very easy to remember. Okay, name, introduction, confirmation of the name and age, and explain the procedure. This is a very important step. For example, I'll explain. Hi, I'm Dr. Rakshit. I'm the exam candidates today. May I confirm your name and age? Thank you for confirmation. Today I've been asked to put a stitch over the small wound that you have on your forearm. Today I've been told that you're unable to pass urine, so I'll be I'll be inserting a tube into the waterworks. It might sound painful, but I'll try to we'll give a numbing agent by which you might not feel that much of pain. I know it's a bit discomfortable, but please bear with me. This is the best method of treatment. So here, what am I doing is I am telling the patient what I am trying to do. I am telling the patient that is going to be uncomfortable, but I am trying to help the patient be calm by telling him that I'll be using some numbing agent, etc. So it doesn't cause much of a pain. Okay, so this has to be explained in a proper way. So some patient might not be comfortable. So until the patient says, yes, you can go ahead, doctor, you're not supposed to go ahead. So here the problem starts. What will the patient say? Sometimes the doctor, he really sounds painful, I'm really embarrassed. Can you please give me another alternative? So here most of the people falter. They don't give alternatives. So I think this is best for you. There are alternatives. So we can go for suprapubic catheterism, we can go for condom catheter, but there are multiple alternatives. But considering your current condition, this is the best and painless method that we can do. Other methods are painless and it might cause more discomfort to compared to this. So it's better if we go through this procedure. So we have told him what are the alternatives are available. We have given him the option, but we have suggested him to go through this. Now the patient is convinced, yeah, I can go through this. Now this is one thing. Okay, so we have explained introduction, confirm the age. We have explained the procedure. Now the consent has been taken. A verbal consent is more than enough. Now, before we begin everything, what are we supposed to ask? We are supposed to ask about the WHO safety surgical checklist. This is something that is non-negotiable. So, what is a WHO surgical checklist is important. So, it basically consists of all the basic parameters that is required before you actually do a procedure on a particular patient. It can be name of the patient, age of the patient, side of the patient. Okay, what are the drugs the patient is taking? What are the allergies? So these are something very basic things that has to be taken into account before you do any procedure. So this is also non-negotiable. Sometimes some things, allergies are very important because we'll be using local anesthesia or numbing agent. So allergies are also, the allergies play a very important role. Tetanus dosage, injection or bleeding disorders. WHO safety surgical checklist actually covers the drugs also. So bleeding disorders, and if the patient is taking any medication for the same, that has to also be covered. Okay, if you're catheterizing, if the patient needs someone, you can ask for a chaperone also. Most of the times, examiner themselves act as a chaperone, but depends on the mood of the examiner. If the examiner is really, he really wants to, he or she wants to help you, they might help you, or they're not going to help you. You're completely on your own doing all the procedure. They might be just sitting there and observing you. So please prepare in such a way mentally that you should be the only one. You are the one suturing, you are the one knotting, you are the one cutting. Remember, okay, we have to do 4 times such a way. So never be dependent on the examiner. Don't think that examiner is going to be your assistant in the exam. They might or they might not be. It completely depends on them. There's no compulsion for the examiner to help you. Okay, so we'll just run over this slide. So consent. So we have explained the consent to the patient. We have explained everything. We have gained a verbal consent and positioning. Positioning is very important when it especially comes to suturing. Why? Because we have to properly expose and properly cover up also. And next is prepare. Equipment expiry. Expiry is very important. I'll be explaining in detail when we go to respective stations where all you're supposed to check for the expiry. Assistant, you ask for a chaperone. You ask, okay, I need a chaperone for this because I need an assistant. Then asepsis, as we discussed previously, perform the technique. We have had multiple techniques. We have done a lot of things in our practice, but here there's a fixed protocol that you need to follow. For example, suturing, some might use a palming technique. That is easier for them. Some might want to take a bite, a single bite. They want to come out from both the sides. No, that is not acceptable. But put a proper knot. So everything it has to be in a proper structured manner. You have been doing it that way. It doesn't mean you can do the same thing here. Okay. Safety, as we discussed, specimen leveling and aftercare. So these are the protocols that need. This is non-negotiable. Okay, after the aftercare is very important. After you finish the station or the procedure, you thank the patient. Thank you very much for your cooperation. That concludes my procedure today. Thank you. Do you need any help with dressing up? So before the station, what we need to do during the procedure and post procedure. So we understood things that need to be followed. It's not just doing that. At the end, dispose all the gloves, everything. Okay, so do not miss anything. I hope everyone has understood. And documenting the procedure. So something we always miss. Documenting the procedure is very important at the end. So I want to document the procedure. So this is the protocol. I hope everyone is clear regarding what are the things that you, if you follow this much, you are safe, that we can safely say that you can clear the exams. And moving on to the next. So here usually the scrubbing is a station that is usually not asked. So nothing fancy here because there is no gown available in the exam. Nothing, just a hand scrub will be there or just a hand sanitizer will be there. Gloves, no touch technique. I think this is all not required when it comes to the MRCS part of the exam. So this is the WHO safety physical checklist. No one is going to ask you in detail what a WHO safety surgical checklist is. No, not required. But we have to just mention about that. So these are all the things. Why surgical checklist is important? Because it consists everything like this. So timeout and sign out. So everything is counted. So this is an important step of any procedure for that matter. We have to make sure we have covered everything in detail. Okay. Okay, so we'll start off with our first important and very important station, that is the OT listing. Why OT listing is important? It's very simple station and it's a highly scoreable station. So that is what we'll be discussing here today. So whenever there is an order, there may be an order that's given to you. So sometimes remember, as we know, before we enter the station, there will be a stem, right? So sometimes in England or Edinburgh, it depends on the examiner or that day organizers. What they do is they put 1, 2, 3, 4 in the outside stem, outside the station, and inside when you enter also on the table they would have stuck that 1, 2, 3, 4 step. So by this way, when you enter the station, you can easily read. Once you remember the pattern here, you can again, if you have any confusion, you can go through the pattern again inside the station also. But sometimes what happens, they would have not put anything inside. So this is the same OT list being put inside the station. It is definitely optional. They might sometimes give you, so they might sometimes not give you. So this is a riskier part. Please do not just read the stem. Make a mental note of the at least the procedures that they are doing and the complications that are associated with. So make sure you make a mental note. Be prepared that there is no OT list inside. You prepare in such a way that there is no OT list inside. Do not be dependent on the OT list inside the session. They might have it, they might not have it. This is very important because a lot of students have made this mistake. They are not mentally prepared. Once they enter the session, there is no list, and they've asked the examiner, so then the list is already given to you. I'm not going to give you anything. So they lost a lot of marks. There is a very simple station. This station can cover up the marks for other stations where you will not be able to do good. So that is one thing that you have to remember. There's a basic that I want to tell you before I start my station in detail. Okay, so as you know, what are the things that actually go first? So we have to know when there is a list of options or list of treatment options that is there. Usually the things that go, if there is a latex allergy. Whenever you see a latex allergy, it always takes the priority. There is no question of anything else because latex has to be taken up first. There is nothing. They won't give it you in such a way that there's clashing between two things. No, they don't do it like that. They might give an emergency there, but it can be infected case or something like that. So they usually do not overlap things that will be a lot of confused to which one to put first. Then again, diabetes goes first, emergencies goes first, like strangulations. Okay, then pediatric kids go first. So these are the things that actually go first amongst the list that they have given you. So these, if you look for these things, whichever takes the priority, usually latex takes the priority. If that is there, you can just put first, or any emergency like strangulation that goes first, or a pediatric age group, and then diabetes. So you can follow this order based on the priority. Usually one of the things will be there. You can just put it first based on whatever it is there. And you can then arrange it, and which we know what goes first. Then now we have to know what goes last. When it comes to last, it's usually infective case. It can be HIV, HBsAg, MRSA, anything goes last, or contaminated cases like a gangrene. Okay, it can be anything contaminated, like necrotic fasciitis, any infections. That all the localized infections, they all go for last, because after that procedure you might need a fumigation there. So that procedure, so we have to know what goes first, then what goes last. So this is very important when you decide. Usually 4 of the list will be given. For example, I'll be giving few examples here. For example, there is a inguinal hernia repair. Patient has inguinal hernia repair, then diverticular abscess, then carpal tunnel decompression, then laparoscopic cholecystectomy. So when you consider this order, what are the orders that go first? When the patient has strangulated inguinal hernia, so there's nothing Nothing can beat the emergency here. So you can directly go with strangulated inguinalergia. Then when the patient is diabetic, for example, this abscess patient is diabetic and is on insulin. So this patient will actually go first. Actually, diabetic patients go first, but here an emergency has come. So definitely goes first, followed by a diabetes mellitus patient goes first. Then depends on the patient here. If they're talking about carpal tunnel decompression, this patient has an MRSA positive. So this patient goes in the last. So we can put this laparoscopic cholecystectomy before this. So this goes third. So depending on types of anesthesia, also you can decide. The questions will be based on that. What kind of anesthesia that you want to give, or what is the things that you have to prevent. Okay, so that is also very important that we keep in mind. So this is some things about the OT listing. Then we'll go to the next part of So based on the OT list, what are the questions that they ask? What are the questions that they ask based on the OT list? So what are the types of anesthesia that we use? What are the types of anesthesia that we use? For example, if it's a GA case or it's a spiral case. Okay, so that is the one thing that we have to confirm. Then the most important thing is diabetes mellitus. What are the guidelines that we do to follow in a diabetes mellitus case? What are the things that we have to do? A lot of points that's given in the books. So we'll try to go through a few of points that's given in the books for diabetes mellitus. What are the precautions that we take in diabetes mellitus? Patient is usually first in the OT list. Then usually second will routine. So overnight admission or overnight starving is usually prevented. Usually one missed meal is enough. Analgesia and antiemetic. So we have to try to resume analgesia and antiemetic as soon as possible. The one important thing is patient has to be depending on the type of the surgery. If it's a major surgery, most of the times a minor surgery, what we do is we just skip a dose of OHA and then we continue later on. If it's a patient is undergoing a major surgery, then what we have to do is we should convert the patient to insulin, because the patient will not be able to take the OHA and wound healing also can affect it. So we can get the patient started on insulin. When the patient has been started on insulin, complete monitoring of this patient is required. So this is very important. We have to maintain this targeted glucose levels during the surgery and during preoperatively. This patient might need fluids preoperatively, intraoperatively, postoperatively. A proper monitoring has to be needed when the patient has been put on insulin. So that is one important thing when it comes to diabetes. Then we'll go with other questions that have been asked. So one complicated question is the pacemaker. So what is the pacemaker? So what are the things that we have to know about pacemaker? So we have to know in detail about the pacemaker. That is a passport of a pacemaker. So where this pacemaker was installed and who did the surgery, what are the details, what is the make of the implant. We have to know everything in and out detail about the pacemaker. Then we have to have all the precautions if this pacemaker fails inside the OT. Okay, we have to have an ICU standby, we have to have a cardiologist standby, we have to have everything that it needs to be in the standby before we actually begin the procedure. During the procedure, most important is using of the bipolar cautery. So what happens in a bipolar cautery? The current runs between the two electrodes. So usually this is what is preferable. Monopolar cautery is avoidable most of the time. So we have to have a complete cardiopulmonary resuscitation unit, and he has to be ECG monitoring during the surgery, and continuously during the surgery is very important. So we have to have everything, all the detail. We have to have the type of pacemaker, everything in detail before we actually begin. And during the procedure also, we should have complete monitoring over the pacemaker, the performance of the pacemaker, ECG analysis. Everything has to be taken care of during the surgery. So most important is cautery usage during the surgery itself. So these are some things that we have to keep in mind. Then going on to the COPD case. So this is about the pacemaker. So what are the things? How do you optimize? So one important thing is how do you optimize the COPD case? What are the precautions that you need to take? First of all, most of the times there will be smokers. So what do you do in smoker? Usually 4 to 8 weeks, preferably 8 weeks. We have to stop the patient from smoking. Then is respiratory physio is important, because these people will have a lot of breathing difficulties. So respiratory physio is important. Post-operative adequate pain relief and an upright position. The patient is preferably in the upright position, not in the lying down position, and over ventilation has to be prevented, because most of the times here it depends on the carbon dioxide drive. So we can't just over ventilate the patient and wash out the carbon dioxide. So we have to be very careful, and we have to start mobilizing the patient as soon as possible so the patient will be able to breathe on his own. So some of the precautions that we have to take in patients of pacemaker and COPD. So these are some of the precautions that we have to keep in mind. Then moving on to the patient who are on anticoagulants. So here there is a communication station which was covered yesterday, I think, that is regarding warfarin. So there is some everything about warfarin, right? So the warfarin is stopped. You have to start the patient on low molecular heparin. If you're doing a cardiopulmonary resuscitation, then unfractionated heparin, because unfractionated heparin can be reversed, but a low molecular heparin cannot be reversed. So here depends on type of surgery that we are doing. For example, the patient is undergoing a totally replacement, then low molecular heparin is preferred. But when unfractionated heparin, because it can be reversed, especially in cardiac cases, unfractionated heparin is used. So these are some of the precautions that we have to be taking in a patient of oral anticoagulants. We have to convert them. Then we have to post-operatively. So it depends on type of the surgery. For example, the patient has undergone a major surgery. It's a pelvis surgery, totally replacement, older age group, more than 2 hours of surgery. What are the important things that we have to remember post-operatively is most importantly is thromboembolic risk. Thromboembolic risk is very important when these are the factors contribute to the surgery. A prolonged surgery increases the chances of prolonged thromboembolic exposure. So immediate mobilization. So there are multiple types of mobilization that we do. One is a mechanical mobilization and one is a chemical. So here chemical is definitely started like Lexane or low molecular heparin, but mechanical, this patient might need pneumatic stockings or early mobilization. Early mobilization is one of the very important ways that we can actually decrease the chances of thromboembolic phenomenon. So these are some of the important things when it comes to OT listing. As I told you, OT listing, more of a procedure, less of a procedure and more of a theory. So this is if you're really lucky, you can definitely get this procedure in your exam, and it's very easy to score complete marks in the exam. So OT listing. So there is one question for betadine allergy. If the patient has povidone allergy, what are the better things that you can use? That is the chlorhexidine. So that is something that we have to remember. MRSA again, chlorhexidine is used. Okay, so I think so. This is about OT listing procedure. I hope everyone is okay with the OT listing. It's a very simple and straightforward that we have to remember. Okay, so local anesthesia toxicity is again an important question. So, what is the antidote for local anesthesia? Also has been asked. So, lignocaine toxicity. What is the dosage of lignocaine toxicity is important here. So, the dosage of lignocaine. What do you do with adrenaline? Without adrenaline, 1% is 10 mg per ml. How do you clean? First, clean. Aspirate is very important. Inject slowly. When do you use adrenaline? When you don't use adrenaline, especially when you're doing digits or suspecting decreased blood supply, then we have to decrease we have to never use adrenaline in these cases because it is high chance of gangrene. One of the advantages of using adrenaline is it prolongs the action. Even there is an infection, it prolongs the action of the local anesthesia. So this is a preferable choice when you want the local anesthesia to act for a longer duration. We have seen this perioral. So, what is the first important neurological sign of lignocaine or local toxicity is perioral numbness. When you see this perioral numbness, it's very important to understand this patient is going towards toxicity. What is the most important antidote is intralipid. Intralipid can be given. First important thing is stop the local anesthesia administration, give intralipid depending on the toxicity. Confusion patient once has neurological symptoms like confusion, seizures, and arrhythmia. So all this is first most important. Stop injecting. So whenever they ask you what is the first step of treatment of local anesthesia toxicity, our answer is stop injecting. Then only the other things come. Okay, ABCD. We can use intralipid for severe cases. Okay. So then we'll go into the station, that is a suturing station. Suturing station is an important station, so we'll try to understand what are the things that we have to know in suturing station. Okay. I'll be talking about suturing station in detail because this is one of the reasons why I'll tell you, because the mannequins for suture materials is very easily available. When you talk about catheterization, you need heavy equipment, you need other things, but suturing station, you need a simple pad. And remember one thing, the pad that is given in the exam is not of good quality. I don't know, depending on the countries maybe, but especially what we have experienced is not of a good quality. The problem with the materials, the suturing pad that's given in your exam is it's not good. Okay, it can cut through. There is a chance of them cutting through. So remember this important. It can cut through. So you have to be very careful. Do not pull on the suture. Okay. So now I will be talking about station. I'll just go through the station how you're supposed to go through in your final exam. So here a 35-year-old female has presented the emergency department with a cut over the forearm. With a cut over the forearm during cutting of the vegetables. Okay, you're the candidate. You have been asked to suture the wound. Okay, suture the wound. So now enter the year. So I'll be just trying to demonstrate how you're supposed to do it in the exam. I can't demonstrate suturing here, so I'll be talking about how you're supposed to do all the other things except the suturing. Okay, because I can't demonstrate that now. Okay, so hi, I'm Dr. Rakshit. I'm one of the exam candidates today. I may confirm your name and age, name and identity each. So once I've confirmed the name and identity, so I'll be explaining to the patient what I'm going to do. Hi, today I've been told to put a stitch over the wound that you have on your forearm. Which what I'll do is I'll give you a numbing agent by which you won't feel much of pain. Then I'll be using small suture material and I'll try to suture them. I'll try to approximate the edges and keep the scar as minimal as possible. Then the actual conversation starts. What are the things that you can expect from the patient? What are the questions that you can expect of it? Doctor, I'm really scared. I'm really scared of all these things. I don't know what exactly to do here. I'm really scared of the sutures and needles, etc. Please do not worry. It will be very safe. I will make sure it is safe. Do not worry. I'll help you with whatever the doubts you have. Okay, shall we start the procedure? Okay, before we start the procedure, as I told you, we have to go through all the things like WHO safety surgical checklist, allergies, washing hands, preparing the tray. Everything has to be gone through. Okay, so these things have to be prepared. So once you have done everything, you understand, you're taken a verbal consent of the patient. Okay, doctor, please do it very carefully, so I won't feel. Okay, do not worry. I'll try to make it as less painful as possible. So that is one thing that you have to give that assertive from your side. Okay, so then the patient tells, okay, doctor, now I'm comfortable. You can go through. Doctor, if the patient tells, I'm really scared. Do you have any other alternative? So most of the times, because we have been asked to suture, what we tell, no, we don't have any other alternatives. We'll go for no. You can't tell that. There are other alternatives. Okay, we can go for a glue. There is a glue, but sometimes what can happen is glue has also its own reaction. Sometimes the glue can react with your skin, and it can cause some redness in the skin, and can sometimes actually open up. Okay. And we have other like staples also. Then considering all this, you want a better approximation under this free suture. I think suturing is better compared to all this. So I would suggest you to go through suturing compared to all these other alternatives. Then you'll feel like, doctor, will it cause pain to me? Like, will it leave a scar? I'm really sorry that it's going to leave a scar, but what I'll do is I'll try to keep it as minimal as possible. You can't tell, no, it's not going to leave a scar. Yeah, it's going to leave a scar. You can't just tell the patient. Patient will be scared. Okay, you're telling me it's going to cause me pain. It's going to cause me a scar. I definitely don't want this. So then here, what is our work is you have to give all the details. You can't hide anything from the patient. You have to give all the details in a proper way where the patient is able to understand, yeah, this is what is going to happen to me. There is going to be a scar, but he told me he's going to keep it to the minimal. So now the patient is confident enough, yeah, you can definitely go ahead with the suturing. So this is how you have to gain the consent from the patient. It's not just going and giving all your information to the patient and just casually extracting the consent. No, that's not going to help you score marks. Okay, that's not how the professional works. Okay, that part is done. Then, so before you begin, what are the things? So most of the times in all of the exams, this is not required. This part is already taken care of. What they do is they keep everything arranged. So they'll ask you to suture. But here we'll go step by step what you're supposed to do. Okay, you finished all the basic formalities. You've got everything ready. Washed your hands. You're prepared. Worn your gloves. So now we'll get all the materials ready. So you have to ask because they are not going to give it to you. First thing is this suture material. The most important thing is suture material. Here you can go for monofilament suture. You can go for number 30 depending on the site. Most of the time it's number 30. So anything that comes in a plastic pack, you have to check for expiry. Very, very, very important. Anything, catheter, it can be a catheter, it can be a lignocaine jelly, or it can be a suture material, or it can be a syringe, it can be local anesthesia. Anything with a label or anything that comes in a plastic cover or anything, you have to check for the expiry date. It's very important. So once you're, so you can just see, check for the expiry date. It's well within the expiry. So I want to keep it aside. Okay, so that is that. Next is the lignocaine. So you have to consider what is the dosage. For example, 72 kg male, 50 kg male. So you can just ask for 2% local anesthesia depending on the weight of the patient. No need for doing exact calculation. You can tell this is the amount that will be taking. So you confirm whether it's with adrenaline or without adrenaline. So preferably without adrenaline. Then you are taken the local anesthesia. Then comes the needles. So what are the needles usually required is 26 and 22. Here, wow, here 26 and 22. What we do is usually one is for aspiration, one is for injection. 26 is a smaller needle. That is where what we prefer for injection. So this does not cause much of a pain. So we'll use it for injection. This is used for aspiration. So these are the things that you have to keep ready. Gloves, suture, drapes, everything is ready now. Okay. So now we can go for suturing as such. Okay, so now you kept everything ready. So once you withdraw the local anesthesia into the syringe, make sure you disclose the needle then and there. Don't keep the needle to the side. Okay, do not wait till the end of the procedure to keep the needle into the bin. Okay, throw it immediately. Most of the times what happens is in this hurry to summarize or you're not able to finish the suture, we usually just leave it there. So that's where you lose marks again. Okay, so that is the important thing. So now we'll be starting the suturing as such in detail. Okay, so now we got everything ready. Now the suturing part. Now for example, this is the forearm. This is the minor wound cut here. Now you can you can tell the patient, now I'll be cleaning the area just with small amount of Chloroxine or betadine. You can just clean it. It might cause some kind of a burning. Please bear with me. Then once you cleaned it, you can just put a drape. This part is not a part of the exam because it's already done. They'll directly ask you to suture. Okay, now comes the injection of local anesthesia. Injection of local anesthesia is a very important part where you have to be very careful. Okay, now how do you explain to the patient? You tell the patient that I'll be now injecting numbing agent into the wound. It might sting a bit, but please bear with me. It will be just for a few seconds. So before you do anything painful to the patient, give a warning shot. This warning shot is important. If you don't give this warning shot, you're going to lose marks again. Okay. So now you've injected local anesthesia. Now you wait for 5 minutes. Because we don't have 5 minutes there, you can just tell the examiner, I'll wait for 5 minutes. Examiner will tell, consider the 5 minutes done. Then you can start with procedure. Before the procedure, because it's a painful thing, again you have to give a warning shot. How will you confirm the agent is working? You have to take a forceps, tell the patient that I'll be just touching here. And if you feel any pain, please let me know. Okay, once you confirm it's numbed out, you can then go with suture. So one thing while suturing is very important. You should never handle the needle in hand. Never touch the needle in hand. Never ever. It is always with a needle holder. Okay, always use a needle holder to touch it. Hold the instruments in a proper way. Okay, always when you try, so what we try to do is when we suture, what we do is we hold the needle in one hand, we'll try to knot it. Do not hold the needle in one hand. Keep the needle aside. Just hold the thread, pull it, then suture it, then knot it. Okay, so one thing that we have to remember while suturing is, so for example, this is the cut. What we do is we take a single bite through both of them and we knot it. That is wrong here. Okay, you take the suture bite here, take the needle out of here, then again the suture bite here, then knot it. While knotting, the knot has to be on side. Okay, knot has to be on sides and not on the wound itself. Okay, it's a very simple knot. Do not tug on this. Do not tug on. If you tug on this, it's going to cut through. Because we don't have time, we have to put 4 sutures. You're going to lose a lot of time there itself. Please practice this. The suture materials are available on Amazon. Just get them and practice them if you're not well versed. Even if you're well versed, please practice them. Because we have seen candidates actually really good surgeons. They're actually scared there because it's a simulated environment. Their exam stress will be there. Definitely you'll get scared even if you're a very good surgeon. So it doesn't matter. Please do not take it in an ego. Get a suture pad. Try to practice them repeatedly. That's how you can just do it in the exam as well. Okay, that's one thing that you have to remember. Then once you're, I can't talk to the suture, so try to do it in a proper way suture because I can't demonstrate it. Many suturing videos, especially BK Medics, is available on the YouTube. You can go through the suturing technique as such. So during the suture, what are the things that say what? As I told you in the beginning of the session, a silent procedure. If you do a silent procedure, consider you failed. There is no need for judgment. There is nothing. You have failed if you have done a silent procedure. This is 100% true. You have thanked the patient, you've done everything perfectly, beautifully, everything is done, but you have done a silent procedure, you have failed. So what is a silent procedure? Not talking to the patient. So here I'm talking to the patients continuously. Don't talk to the examiner. Examiner is not bothered if you talk to him or not. If you don't talk to the patient, you're losing a lot of marks. So talk to the patient. What are the things that you're going to talk to the patient? It might leave a small scar, but I'll keep it as minimal as possible. What are the complications that you can expect? There are for example, the patient is asking you, doctor, will there be any complications? Hi, so yeah, I totally understand your concern. Every procedure has its own set of complications. That doesn't mean that all the procedures have these complications. Please do not worry. We will try to keep the complications as minimal as possible. But you have to know what are the complications that can occur. For your understanding, I'm going to tell you this can be a possibility, but please do not worry. This is a very rare scenario. It might occur. So you're telling about the complications also, you're giving that confidence to the patient that is very rare. And you have to suggest him if these complications occur, what he's supposed to do. Everything has to happen during the suture. Don't wait till the end of the procedure to give all the instructions. That is completely wrong. Okay, so what are these complications? So you can have some kind of itching. It can cause redness. If you notice any kind of a swelling, if you notice any kind of a foul smelling discharge, okay, all these are immediate complications. In this case, you have to report immediately to the emergency department. Okay, and watch out for these complications. You can take a shower. If you're using a waterproof dressing, you can take a shower. If there is no waterproof dressing available, please avoid water contact on the wound surface. If the dressing gets wet, please get it changed as soon as possible. You can go to a GP and get it done. Okay, if it's a clean wound, antibiotics are not required. If it's a contaminated wound, for example, it's a simple kitchen knife wound, there is no need for any antibiotics. Just suture it and send them home. There is one confusion always regarding X-ray. Why do you need an X-ray when it comes to a simple kitchen knife injury? If it's a road traffic accident, if you're suspecting a contamination, if you're suspecting foreign bodies, then go for X-ray. No? What is the point of getting an X-ray in a simple kitchen knife clean injuries? Even if there is vegetable contamination, I don't think you're going to see an X-ray. Okay, if it's minor contamination, give a thorough wash and you can do. I don't think X-ray has to be a part of all the suturing. I think you have to think about it. I don't think it's required in your practice or in general. There is no advice for X-ray until you suspect any foreign body contamination. Okay, or else you can just skip this part. So if you're suspecting any contamination, if you're confused what kind of antibiotics to give, you can just tell at the end. As it's a contaminated wound, I want to start your antibiotics, but the antibiotics can be started according to local trust policy. So in this way, you convince the patient that he needs antibiotics or not, and you can get it done. And dressing, you can get the dressing changed from your GP. You can get a suture removal usually by 7 to 10 days. Okay, if the complications are there, he has to come to the emergency. Otherwise, you can just go to the GP and get it removed. So these are some things that we have to talk during the procedure. So by this time, if we talk during the procedure, in the 6 minutes, we have actually spoken to the patients. We have given him post-op instructions. We have told him about the complications. We have told him about the follow-up. So everything, the whole station is done in 6 minutes. If you wait till end of the 6 minutes, you won't get time because you have to eventually summarize. You have to talk to the examiner regarding the Viva. Okay, there are few Viva questions. So I might not go into details of the Viva questions. So what are the things that they usually ask in the Viva? I might here. I think we have some questions. I'll just see if we have questions. I hope everyone is understood. Here we are trying to put something. Just give me 1 minute. Yeah. So this is the Vicryl is a braided and absorbable. No need for Vicryl. Usually 3-0 nylon, 4-0 nylon is difficult to put. Usually we use a simple mattress suture, simple interrupted suture. There is no mattress or subcutaneous suture. So the only suture that you are supposed to know is simple interrupted suture. Okay, some of the questions might be regarding what are the suture materials that you use, what are the complications of local anesthesia. Okay, so this is post-operative instructions given, preparation, local anesthesia. So we've spoken about everything. 21 gauge and 25 gauge. Okay, what are the doses that we use? If it is plain xylocaine, 3 mg per kg. If it's lidocaine plus adrenaline, 7 mg per kg. If the patient, what is the dose of bupivacaine? So these are some of the common questions that we use. What are the chances of risk of infection? If there is clean contaminated wound, there is no risk of infection itself. Okay, so it will be very simple and very basic questions that are usually asked. So I think this part is clear for everyone. Okay, we'll be moving on to the next part, that is a knot tying. Yeah, so very simple, very easy to understand. I'll tell you why. See, the problem most of the students actually falter is in this station. If you fail, this station will be responsible for your procedure. Why? I'll tell you. Because here we're supposed to tie 2 knots. Okay, one is a knot tying at depth, and next is a knot tying, superficial knot tying, and next is the hemostatic suture. You're supposed to do 3 things here. Okay, usually there is no patient here. If there is a patient also, it doesn't ask you much. But you're supposed to do 3 things. If you're not practice this, not good. Even if you're very good, If you just stumble a bit, you're going to fail. Why? I'll tell you. Okay, so most of the times, if there is no patient, no pre-introduction, pre-procedure introduction, everything is not required. If there is only patient, then all these things is it. So when you enter the station, your stem clearly stays. Tie two kinds of knots. One is not tying at depth, and one is not tying superficially, and put a hemostatic suture. So this is your task. So your whole 6 minutes has to be divided into 2 plus 2 plus 2. So practice this. You have to do this in 2 minutes. This is how you practice. Okay. So there is one video on YouTube. It's from RCS Ireland. Okay, RCS Ireland will tell you how to suture from depth. It's a beautiful video. I'll tell you how to practice at home. So how do you design this depth? So this is where we get confused. How does it depth come? I'll tell you how. I'll just draw it and show it to you. Why most of the people actually fail in this suturing of depth. Superficial tying is very easy because it is reef knot. One knot that we have to, everyone has to know. So there are multiple techniques that's available. It depends completely on you to decide. So one is knot tying superficially. So this will be two bands like this. So you're supposed to tie knot tying superficially. It will be here. So this is very simple. Usually four throws are required. 4 knots. So more than 3 throws. That is usually 4. So that is the minimum requirement of superficial knot tying in depth. The problem comes, it doesn't come here. It's very simple and straightforward. You just practice multiple YouTube videos available. So one is knot tying at depth. The problem here is they would have put a magnet here and there will be a hook here. Okay. So this is a small hole. So you're supposed to tie a knot here. Tying this is easy. The problem is if you pull this, this is going to come up. If this magnet comes up, your case is done. So this is why knot tying at depth is important. Okay, so always remember why this knot tying at depth is important, because this magnet should not lift up. So how do you do this setup at home? Take a small glass. It can be Scotch glass or glass. It has transparent glass. Put a small magnet and a hook. Design this at home itself. We have one set by Merrill. Okay, you can go through this. It's available on Amazon. It's cost here 2,000 rupees. But the problem with Merrill set is the hook inside this is fixed. It's fixed and it's very easy. You'll be very confident if you do this. So do one thing. You can do this knotting can be done on anything. You can tie it on a chair handle or anything. This knot is very simple. You can practice on anything. This hook is prepare this kind of a setup at home and practice on this. The suture material usually given is smaller materials, like it can be Vicryl or simple material. So practice with smaller materials. If you want it to make simpler, when you want to learn initially, you can use shoelaces. How does a reef knot look, everything. If you want, you can just leave a message after this in a Telegram group or WhatsApp group. I'll share you the links for all these suturing kinds of thing. You can go through them to understand how exactly do it. But get this set up at home for your better practice. So this is very important when it comes to your suturing or knot tying station. So these are 2 types of knots that they expect from you. You're supposed to do 4 throws in both of the things. So that is very important. And the next is the hemostatic suture. It's very simple, not at all complicated. It's like simple suture. It's also called as figure of 8 suture, right? So it's like this figure of 8 suture, like this. It's figure of 8. You start from here, go there. Then you take the needle here, start from here. Then you put a knot somewhere here. So this is a hemostatic suture. This is also available on YouTube. I'll just share the links at later on the Instagram. On Telegram. So you can go through them. Please do remember that. And here they're trying to see how your hand coordination is, hand movements is. So this is very important. You practice them as much as possible. Okay. Yeah. I hope everyone is clear regarding these kinds of sutures. Okay. So here sides. So depending on types of steri-strips, glue and steri-strips, small, low tension and clean, but they might not hold. Okay. Tetanus stasis and debride and irrigate. Yeah, suture removal usually 7 to 10 days is preferable, depending on whichever things are using. Okay. Next, moving on to 2 important aspects of suturing. So one is not suturing, wound care. So one is abscess drainage, and second one is nevus excision. So how to deal with abscess drainage and nevus excision? So abscess drainage is simple like this. So usually they'll have a small pad and they'll have a small abscess like this. Okay. So here you have to do all the previous things that we did before you start the procedure itself. Okay, like the intro, the physical checklist, confirm the identity of the patient, wash your hands, wash your hands, introduction, confirm the identity, WC checklist, allergies, tetanus. Okay, everything has to be spoken of here before you start. Then again, confirm the identity, then asepsis, draping, then local anesthesia injection, everything. But here, so once that is everything is done, so how do you do? We take a linear incision over this. Then the one important thing that we have to remember in abscess drainage is we have to break the loculations. As soon as you take the incision like this, there will be some yellowish liquid that will coming out. This is in the mannequin. There will be some wax kind of a structure that's coming out. So you have to put your hand inside this and you have to clean this everything. So you have to break the loculations. Okay, you have to break the loculations. This is very important. You just take the incision, the fluid is coming out. You just don't leave it there. Okay, break the locules. Put a hand, break the locules, clean it everything. Take a gauze piece, clear it everything. At the end, leave a wick inside. Give a thorough wash. Okay, give a thorough wash. During all this, again, keep talking to the patient. Yeah, this looks pretty. So once you give the incision, this looks pretty infected. We'll try to take this fluid and we'll send it for culture sensitivity to better understand what is causing, what exactly is causing. So how do you take this culture sensitivity? As soon as you take the incision, there's some fluid coming out. You can tell the examiner, I want to send this for culture sensitivity. So I need a culture swab. Okay, if there is available, they'll give it to you, or else consider that to be taken. Then you can tell the patient that now we'll be taking the culture and sending it for a culture to clear this wound better. Until this comes, we'll start you on broad spectrum antibiotics based on the local trust protocol. Okay, so yeah, so there are some of the complications that are associated with that. Because this is an infected wound, there is chances that this might leave a larger scar. So, but we'll try to keep it as minimal as possible. But we'll not be suturing this wound because there is a lot of pus collection inside. So this keeps on coming out. So we'll be suturing at a later date when the complete pus is come out. So I'll be just cleaning the wound and I'll be giving a thorough wash and I'll be packing this wound, but I won't be putting a suture as of now. We'll be starting on antibiotics and regular dressings, then we'll try to suture the wound at a later date. So it might get complications if the antibiotics are not working properly. It might cause some infection. The infection might spread. But do not worry, this is not a known complication as such because we're taking proper care and giving you proper antibiotics. So it might give a ugly scar, but we'll try to keep it as minimal as possible because it's an open wound and a larger wound. So this is something that we have to give, and there might be some complications as well. This infection can reoccur. It might cause severe pain, redness, or any kind of discharge, any foul smelling discharge. If any of the things you notice, please do visit the emergency as soon as possible. Okay, so these are some of the things that we have to take care in abscess drainage. So the one thing is procedure has to be documented at the end. Culture sensitivity has to be sent. Make sure if you tell the examiner that I'll be filling out the form for culture sensitivity. Okay, so here this is regarding abscess drainage. So give a proper wash. Okay, so consent, adequate anesthesia, incise at the maximum flatulence level, then fluctuance level you have to influence, then break the loculi is very important, then pus culture, pack, leave open, very important. Antibiotics don't replace the drainage, heal by second intention considering the underlying cause, safety net follow-up. Okay, I hope everyone has understood this part. So along with this, I want to cover one more important topic of nevus excision. Nevus excision, we don't have proper videos on YouTube for nevus excision. There's one from Ireland, RCS, but it's not that great. But it's very simple, very straightforward, nothing to worry. So simple like this, there's a small nevus, you're supposed to excise. So all our previous discussions that we did, hand washing, consent, WHO, everything remains the same. There is no change in that. So one important thing is regarding the marking 1 centimeter, 1 centimeter, 1:3 marking we have to do. Then we have to excise this. So here the patient might be apprehensive, okay? Here the patient might be apprehensive, so doctor, is it cancer? Is it going to spread if I don't take it out? Do you think it's cancer? Mr. So-and-so, it's really early to get into this. We'll try to understand what exactly is wrong with you by taking this and sending for histopathology. So we exactly can help you with the treatment. So by this way, we are actually telling the patient that we're trying to help him and we're telling that we're doing this test to understand his condition better. So you need not be scared as of now. We do not know what exactly is wrong with you. We'll try to find out and we're going to help you with the same thing. Okay, so that is one conference that you have to do. Then one thing, so once you have done everything, you're painted, you're given local anesthesia, you waited for some time, then you're confirmed there is no pain. So you start from one side, you incise here, hold it with the forceps at this edge, lift it, and then you have to cut it below. Okay, cut it and lift it like this. So once you lift it, the whole of the thing will come out. Okay, it leave a void like this. Then you have to tag this at one end. Okay, very important. What we do is we just remove this part of the specimen and keep it aside. No, tag it at one end. Okay, we put a suture at one end. Then you have to fill out the histopathology form. You have to fill out the histopathology form, and then it's we have to send this. Okay, for histopathology. Always document the procedure. Okay, then you have to suture this. So this is about nevus excision. I hope everything till now is clear. Okay. So these are the major procedures. Now going on to one more major procedure, catheterization. So either OT listing, suturing, and catheterization. So these are the three things that very highly you'll definitely get in the exam, because we have very limited number of stations in procedures. So definitely catheterization, suturing, and OT listing. One of the three will definitely be there. The other can be. It can be two of the three also. So very high chances, please keep on repeating. So practice as much as possible. Moving on to the next very important stage of catheterization. So why very important? Because we sometimes mix up things here. So we tend to mix up things. We don't know what exactly is happening. So yeah, so we'll try to understand how to easily crack catheterization as a procedure station. Okay, yeah. So here we'll start with again the basics of all the procedures that we have followed till now. We followed with the introduction. I am Dr.RAKSHITH. On the exam candidates today, I have been asked to put a pipe or a catheter. It's a small rubber tube to penis. You can tell penis if it's a male, female, doesn't matter. You can use the word medical terms in the here. Or you can use waterworks. So if you want to be more casual, yeah, that is also unacceptable. So yeah, so do not take history. Many people keep on taking history. How did you have how did you cut yourself? What is the problem? What makes you visit the hospital? Not required. What is your task? What does the STEM say? STEM says put a catheter. Your work is to put a catheter. You don't want to know, oh, he has a BPH, he has some obstruction, he has a trauma. Why do you want to know? You have been asked to put a catheter, put a catheter. Don't do extra. That is not required. You're not going to get any method. You'll lose marks more. Okay. So one introduction, confirm the identity, then proceed with the station 1 WHO checklist, latex allergy. Allergy is non-negotiable. You have to ask everything or you're going to lose marks for sure. And everything is comfort. So here when you're preparing things is very important. Okay, one is when for local numbing agent we can use Lox jelly. For local part preparation we can use normal saline. We do not use povidone iodine for cleaning the genital and around the genitalia. We use normal saline. Okay, then we can have catheters and urobags for all the. We have to check the. Expiry date for all these things. Whichever comes in a packet with a label, you have to make sure you check for expiry dates. Then you can proceed with other things like linens. What are the linens? Absorbent pad. Then we need a kidney trace. Okay, so here catheterization urobag, kidney trace, then syringes, and along with that distilled waters, gloves. So everything has to be made ready before you actually start the catheterization. So this is here because you'll be exposing the private part. So you have to make sure that you have a chaperone always with you. Because the very important thing is you have to always have a chaperone. You can't do it alone. Okay, remember that. You not even ask the you need not ask the examiner that the patient that you want to have a chaperone or not. You just tell the examiner I want to have a chaperone. Okay. So once you have done everything, you get exposed. So you have to warn the patient before exposing. So once you expose the patient, you got everything ready. You take normal saline. This is the first pair of gloves that you wear. You wear the first pair of gloves and you clean everything around. Okay, you clean everything around. Then hold the penis and clean the penis. We use around 2 to 3 gauzes. So one is for holding the penis. Then you can start from tip and go backwards. Then you clear the tip. Okay, so then you have to you have to keep an absorbent pad below the penis. Below the buttocks of the patient. Then you can change the gloves. So where do you change the gloves? Usually after cleaning, you can change the gloves. Okay, after cleaning everything, you can change the gloves. Next, you can go for instilla gel administration or local anesthesia administration. Here, it might cause some pain. You have to warn the patient. Here, the patient might ask you for alternatives. Doctor, see, it really sounds painful. You're putting a tube in my water work, so I just want need some alternatives. Do you have any alternatives? We do have alternatives like we have suprapubic catheterization or condom catheter. That might not help you that much because there is some obstruction. The urine is not coming out. So to make sure the obstruction is relieved, so this is the best and simplest way. Be assured that we will be as gentle as possible. We'll use numbing agent so it does not cause discomfort to you. Please bear with me. It's a very simple procedure. I'll do it as soon as possible, and it's not going to cause any discomfort to you. So give that confidence to the patient before you actually catheterize. So then you instill a gel. Then you wait. Okay, then you wait. Tell the patient that I'll be putting a gel numbing agent inside the penis or waterwork. So it might cause a bit of a discomfort, but do not worry. Once it goes inside, you won't feel much of a pain. Okay. Then you confirm the catheter size, catheter expiry, everything. Then you have to hold the penis and put a catheter inside. So once you pass the catheter inside, so once it's gone inside, then see, most of the times what these mannequins actually have a reservoir inside, but they don't fill water inside the reservoir. So urine does not come out. So you do not be surprised if urine comes out. It doesn't come out. We have not seen urine coming out till now. So do not worry if they tell you the urine has. You can tell the examiner because I pushed it inside. The urine has not come out. Now your actually viva starts. So they get okay. So doctor, now the urine has not come out. What do you want to do? So yeah, so I'm suspecting some kind of a blockade here or anything. So I want to give a suprapubic. We'll start with simpler things. Okay, we'll give suprapubic pressure. Sometimes suprapubic pressure. Okay, give suprapubic pressure. So you're given suprapubic pressure, but urine still doesn't come out. Then the examiner tells you what do you want to do, and then I can just tell. Now I want to flush it because there can be interstitial obstruction. Then you can flush it. If still it doesn't come, then I do not want to inflate the balloon, but you might want to do it ultrasound done, or you can do suprapubic SPC catheterization done. So these are some things that we have. The viva goes on like this. If the patient has a latex allergy, with the patient, if you inflate the balloon even before the urine drains, okay, what are you going to do? So that what are the complications? Urethral injury, urethral stricture. So all of these are the complications of catheterization. So once you inserted a tube or connected the uro bag, urine start coming. Then only inflate with distilled water and not normal saline. So after this, you can cover the patient up, thank the patient, document the procedure, wash your hands. Then you start the viva. Okay. So this is how the procedure has to go through in a simpler way. This is also a beautiful video on the YouTube on Geeky Medics. You can go through that. It's very simple, very straightforward. Do not complicate this because it's very straightforward, very easy. I don't think you can make mistakes in this if you practice repeatedly. You don't need a mannequin here. The one thing that you have to remember is no touch technique. What is no touch technique when it comes to catheter removal is? So this is the cover of the catheter. There will be a small partition here. Catheter is inside here. Okay. There's a catheter inside here. So once you take out this part of the catheter, you have to hold it here. You should not touch this catheter. Okay. So this catheter has to go inside the penis and you have to hold this here. You keep on retracting this plastic cover and this catheter keeps on going inside. You do not hold the catheter with your gloves here. Okay, this is called no touch technique. This has to be followed. But again, the problem in the exam is they don't have 20 catheters. They can reuse the catheter. They just throw the catheter there. Then you can tell, I want to use a no touch technique like that. Just you can tell them orally. Most of the times, it doesn't work like that. Okay, it doesn't work. The scenario that you have imagined that you have practiced. Sometimes, if you have a bigger, especially males, if they have bigger hands, they would have kept 6.5 disposable gloves there. It won't even fit in your hands. It might tear repeatedly away. Then you can tell like these gloves are very small for my hand. I can proceed like that. You can't do anything. You have to modify depending on the situations. Okay, so some things that you have to keep in mind. This is something that actually happens. Okay, this is very commonly that we have seen. Many students have given feedback like this has happened to me. So yeah, you have to improvise depending on what is happening on that particular day. Okay, so this is about catheterization, and I think now we have discussed almost all the procedures in detail. I don't think anything that is left. We'll see what all is there again. So consenting, when it comes to consenting, as I told you, the layman language is a very important language. So please practice like we are using words like tummy, a small tube. Please use that. Benefits and realistic success. Okay, it's not like it's definitely going to relieve your urinary obstruction. We'll try to relieve. Okay, we'll try to do our best to relieve we'll try to make sure that you pass your urine. It's definitely going to relieve. No, don't give that false promises. Just always give a realistic approach. Okay, material risks Alternatives is very important. Make sure that you always give alternative and complications. Never lie to the patients, including doing nothing. You can just leave it there. Okay. Plain language, chunk and check. Invite and answer the question. So always ask, do you want to ask anything? Confirm understanding. So it's not about you just explaining everything. It's about making sure, yeah, the patient has got it. Okay. So confirm and understanding, document and discussion. Very, very, very important. Okay. So this part we have understood. Then positioning. So this is not required as such. Usually, we have decided needle holder, artery forceps, and retractors are not there. Needle holders, artery forceps, tooth and non-tooth forceps will be there. Mostly tooth forceps is what is there. So whatever is there, it is there. You can't expect that I prepared with this. Ideally, the situation is different. The exam, the situation is different. So you have to modify and whatever is available on that particular time. There. Okay, so remember that. Antibiotic prophylaxis is one thing where required, like abscess drainage, it's required, clean wounds not required. If there's bleeding, you can use tranexamic acid, but this is for surgeries, there major surgeries. The surgeries that we are doing in procedures are very small and not required. Okay, so now we have completed everything, the procedure stations. So we completed everything in detail. So then we can start the circuit. We can go inside. So how exactly the circuit? I'll explain to you how the exam is conducted. Okay. Okay. So as we discussed, I'll go in details of the circuit. How a circuit looks like. Okay. So when you start, it is not in this particular order itself. Okay. Sometimes it can mix and match. After anatomy, you can have examination. Okay. After anatomy, you can directly have critical care. So it doesn't follow any particular order. You can have knowledge followed by skill followed by knowledge. So it's very confusing. Now, what do we think? We'll start with anatomy. You'll have this basic mindset and go. So this is very important that it does not follow any particular order. It varies. 70 stations, 9 minutes for the task, plus 1 minute for the stem. So this is overall 10 minutes for all the stations. This we know. 70 stations, manned and unmanned, usually 9 minutes. So knowledge and skills, rest stations. There usually only one rest station that we get is the prep station is one, and before the prep station we might get one rest station. But or else it's usually a continuous flow. So one thing is do not carry over. It's telling is very easy. I can tell every time I take a class I tell don't carry over. Don't I myself I can't do it. Okay, it's very difficult. So that's where the practice comes in. Attend mocks, attend regularly, have your own mocks if you have own group, or attend regular mocks anywhere. So make sure that you do not carry over. If someone is very good in anatomy, I'll tell you the scoring area, anatomy. You have to score as many marks as possible. Practice anatomy. Most of it is very basic things that are asked in anatomy. Make sure that you understood anatomy in detail. Okay, so one thing, see, for example, you give an image like this. Where are you looking the image from? You're looking from the anterior side, from the posterior side, medial side, lateral side, looking from a foot. Which part of the foot is this? Which is the fifth metatarsal, which is the first metatarsal? First 5 seconds is about understanding the orientation of the image. Then only you start identifying. You just don't jump into conclusion. Yeah, this is that is that. You might get confused. Sometimes people get tibialis anterior to peroneal. Okay, they're confused with posterior tibial artery to anterior tibial artery. So always make sure that you understood the location, the image, how the orientation of the image is. The images are pretty clear. It's a dissection based image, dissection images. The images are not taken from any source that we know of. Most of the times the images are, we don't know exactly. Internet, you can go through internet, go through dissection images. Have at least 5 images for one particular reference, especially the recent exam that was concluded. We had extensor compartment of the breast. It was a new image. Until unless you do not know the orientation, you just can't mug up the images and go there. So that is about anatomy. Pathology, some people find it easy, some people find it difficult. I think it's moderate. If you ask me, the easiest being the anatomy and high scoring is the anatomy. The second comes the pathology. Then comes the critical care. Critical care can be a pain, actually speaking. Of the 3 stations, you can have one really tough station. Other 2 stations are manageable. But overall, in the skills part, if you're failing, the high chances of you failing is in critical care. So do concentrate on critical care more if you want to just balance it out. Anatomy can help you cover the marks that you lost over critical care. Okay? And rest all skills part are all we have discussed. So yeah, we'll go there. So this is the basic thing. Now I'll going into the scoring system and this. Okay. So I'll tell you the scoring system in skills part. In skills part, the scoring system is pretty simple. Okay, 20 marks, 10 questions. Okay, 2 marks per question. Depending on how many points you are asking, 1, 2, 3. It can be 0 to 1 or 1 to 1.5 or zero point 0.5. So that is how the marks are divided. So again, you graded into 3 categories. One is fail, that is proper fail. There is no chance of you passing. Either you can be borderline pass or borderline fail. So it depends on like zero point 0.5 marks here and there. You can pass. So that time borderline pass or borderline fail will actually help. So yeah, that is how you classify the marks in knowledge parts. It's plain and simple. Okay, then okay, so identify skill stations. So this is what we have discussed till now. So yeah, here I think we have already discussed the communication part, spikes and SBAR protocol yesterday. IES also has been discussed. So this is all discussed in the yesterday's class. So yeah, so WIPE is the examination station. So this all we have discussed already. Washing your hands, introduction, explaining to the patient procedure. Okay. Skill stations, procedure stations. Today we discussed everything in detail. Consent, talk to the patient, walk through, explain to the patient asepsis, like be confident, label the specimens and dispose. Okay, why common reasons the candidates fail? This is very important. I'll go to take some time here. So running out of time. See, one thing always remember, except for one station, that is this spine examination. I don't think there's any station in MRCS Part B where you're running out of time. It's not at all possible. The time is more than adequate. If you're running out of time, any knowledge or skills part, you're doing some mistake. Your practice is somewhere it's lacking. Okay, please improvise that. There is only one station that is spine where you can't complete because it's very lengthy. It's understandable. Everyone can understand if you get a spine because you're not able to complete the musical examination. It's completely understandable. If you're not able to complete a knee examination, you're not able to complete a back exam. Any other shoulder examination or abdomen examination, you're going to definitely lose marks. There is no station that you can't complete in 6 minutes. If you're doing it, if it's 9 minutes, if you're not able to complete, you're doing something wrong. So remember that. History, I think you can complete in 5.5 minutes. So almost everything you can complete in 5 hours. You can't be disorganized. There has to be proper systematic features. So that's why I told you, be a good actor than a doctor. So practice in a proper way. So you have proper organized follow through. So do not mix and match. Don't do that. So no differential. Very important to have differential diagnosis. Then only we go for management. That's how you score for marks in the Viva. So unsafe, sharp, sterility, dose, poor communication, a silent station, carrying bad station forward, definitely not going to help. All this is important when you are discussing MRCS Part B. Okay. Exam day, before when you appear for the exam day, they usually brief you everything. Have a good night's sleep because if you're on second or third day, there's high chances that you can repeat. But first day, because you're the first person, you can have. So remember one thing, in MRCS Part B, we already know the complete paper. We already know the questions because it's a fixed thing. When you compare it to the MRCS Part A, you can have 10-15 new questions. But when you come to MRCS Part B, almost everything is fixed. We know everything. We know everything in detail. So there is nothing that you're going to study the previous day. You have known the whole of the paper for the past 6 months. I don't think you need to even bother the previous day. Okay, just practice. You want to practice, otherwise nothing to read. Read the candidate. One important thing is, for example, I'll tell you how a candidate got confused. There was a station where they actually explicitly mentioned this patient has undergone a varicose vein surgery. Now the patient has difficulty in walking. Please examine this patient. So where are we going wrong here? We have read varicose vein, but we did not read the last part where this patient has difficulty in walking. Why is this patient is having a difficulty in walking? It's not because of varicose vein surgery per se. It's because of the complication of the varicose vein surgery. This patient has a CPN injury. So that's why this person went on to do the varicose vein examination. So here, last part of this term is very important to understand what you're supposed to do. Okay, unnecessary history taking, unnecessary communication, where it's not required, is not going to help. Okay, reset after each bell, use prep stations carefully. Okay, opening structure. Your opening introduction, the way you're talking, your body language decides the flow for the next 9 minutes. If you are very underconfident, you have missed some steps, you are all over the place, distributed, looking here, scared, you're sweating. No, that's not going to help. If you get scared in a simulation, how can they imagine you treating actual patients? So this is very important. Watch the time, keep moving. Do not get stuck in any part. If you're not able to do it, skip it. Go forward. Come back later. Do not wait in that particular station for a very long time. You're going to lose marks again. So remember all this. Okay. Here we'll try to discuss all this in detail. We'll see how to do these stations. Okay, going on to the first question. So usually, very simple question here. So this is how the stem can be, or this is a part of the Viva. Okay, this is a part of the Viva where they'll basically ask you a few questions. What is the maximum dose of pain lignocaine, the suture that you'll be using in suture, what you check before anesthesia itself. So if I discuss everything in detail. So one thing is 3 mg per kg is the dosage of lignocaine with adrenaline, without adrenaline. Then what is 1% of lignocaine is 10 mg per ml. Then with adrenaline, 7 mg per kg. Usually 30 nylon, I don't know why. I think it's better if you go with 30 nylon. 40 nylon is very thin and very difficult to suture. And facial sutures, I think we can use 40 nylon. But it's a forearm suture, we can go with 30 nylon. Check distal nerves, tendons and circulation. Confirm tetanus status, clean and irrigate. So these are some of the things that we have to do in suturing. Knot tying at depth to control the bleeding point. What kind of a knot do you use? How do you protect the deep suture and how do you secure the blood vessel? Very important is one thing that we use the one knotting system. We have to know compulsorily is the reef knot. Make sure that you use the reef knot. Depending on what kind of a knot you are using, it can be single hand technique or double hand technique. Depends if you're on your proficiency. Please do a proper reef knot. Okay, that is very important. Figure of a transfixion. This is a hemostatic suture. Pressure and identify diathermy and ligation. So usually what we do in a knotting station is a deeper well is a larger vessel. We usually try to ligate. Avoid damage to adjacent nerves and vessels is very important. A man with acute urinary retention needs catheterization on a mannequin. So patient is anxious. So when you are doing a mannequin, make sure you prepared. So I think we have discussed in detail. I think I need not go into this in again and again. Wait till the urine flow, very important. And how do you inflate? How do you talk to the patient? Consent the patient is very important. Okay. So here it's written saline. Please forget this. This is wrong. It's not saline. It's distilled water. You're scrubbed and asked to remove your gown, so this is not a part of MRCS. Asked to incise and drain fluctuant mass, so this is like abscess drainage station. So what is the preparation? How do you prepare? So again, the preparation we have discussed. How do you break down the loculi, incision and drainage, antibiotics? So very important. So triator list, strangulated hernia goes first. Septic emergency takes the priority. So this is the Okay. So here one thing, see, disposing of the needles. Needles have to be disposed in a way that you need not recap them. Do not recap. Never recap the needles. Exceed the local anesthesia. So you can just tell if you consider the weight of the patient, or else you can ask the patient itself what is your weight, or you can take it as usually well-built male or moderately built female, like that. You can take that and take an average dosage. Then clean the wound. Then inflate the catheter balloon before the urine flows. So this is where all I think you're going to lose marks. Then dispose the sharps. Stay with the maximum dosage. So I think this is all we have to remember during our station. So yeah, consent, prepare, asepsis, perform safety aftercare, lignocaine maximum dosage, no adrenaline endarteres, vicryl. Because we are not using vicryl, is absorbable and loses its strength. So knots. I think so. We have discussed everything in detail here itself. Okay, so read the stem well, reset of traveler. So yeah, so no problem here. So this is spot pulse, that is maximum low 3 mg per kg, 10 mg per ml, suture, forearm cut. I think this is a repeat of whatever we discussed now. Okay, so the suturing is CH30 nylon, maximum dose of lignocaine. Yeah, so okay. So these were the recent recalls that were from 2021 to 2026. So these are some of the recalls that have come in the recent exams. So tie the knots, figure of 8 bleeding, hemostatic suture, tying at depth. Okay.
Vicarial suture, what are the sutures that we use, what are the advantages of braided suture, when do you use a suture, braided suture. These are some of the things that we have to use. Okay, I think, yeah. This is all repeats that we have discussed till now. Yeah, so that gets to the end of the session here. So we have completed our whole marathon series. I think everyone who have joined for the past few days, I hopefully think you have got your at least some part of your preparation has been really found helpful from our side. We have tried to help you. We request one thing from your side is feedbacks. We have done a lot of effort that's been taken into doing this, arranging this. The marketing team has done a fantastic job, and we have a lot of students actually participating here. I hope will be a part of your preparation in the future as well. We have multiple groups on Telegram. We have weekly ones. We have free live sessions on Zoom. Everything will be posted in Telegram group. You can join us on the free sessions to discuss with our expert mentors. Please do utilize the resources that's my mentors who are practicing currently. They're going to help you with everything. Do leave your feedbacks on how we can improve our sessions and how frequently do you want such kind of sessions, and what all the benefits do you think actually got from the past week of this marathon session? I think people who are appearing for the exams in the next few months or days, I think you are really prepared well. I hope this has actually helped you in your preparation to boost your confidence for upcoming exams. Wishing you all the best from Study Medic side. We'll be here to help. You need not be our course candidate. We have a free group. We have mentors available all the time. We're definitely going to help you in preparation. If you have any doubts at all, you can definitely leave messages in the